So now that we are finished with the part 1 of our case scenarios, everybody, let us move on to the part 2 of our clinical vignette video, in which I'll be posing some simple questions to you. They seem simple, but we have either not thought about answering them or we have been afraid of answering them. But we already know the answers. We just have to think about them, think simply, and answer these questions. So Viva usually progresses with yes, when somebody will ask you the question, your examiner, you will do this, you will do this. But if you are not doing this, that means you have been able to answer all the simple questions, and now you are a gold medal consideration student. Then you are asked such questions. These are questions which use your clinical bend of mind, everybody, which ask you to utilize the facts that you know into clinical scenarios. And that's what we're asking. Let's see the first question on the screen, everybody. During orbital surgery, a patient's lacrimal gland is removed. Okay, lacrimal gland leads to production of tears. Yet afterwards there is no complaint of tear deficiency. Why not? Very simple fact-based question. You just have to think about it clinically. Even though the lacrimal gland is removed, located supratemporally, everybody, yet there is no tear deficiency. Why not? Why not, everybody? Why not? Think. So if you think about it, then we know that tear production, we have two types of tear production: basal tear production and reflex production. Reflex production is by our main lacrimal gland. Yes. Whereas basal tear production is by accessory lacrimal glands of Krause and Wolfring. Yes, these are situated in the fornical conjunctiva, fornix or fornical conjunctiva. So basically, if you understand, it's a simple fact that we know tear production, yes, is been converted into a clinical case, that even though my lacrimal gland is removed, but my basal tear secretion is still normal. So I will not complain of any tear deficiency. I hope you understand this very simple question, very, very, very clinically oriented question, right? Let's move on to the second Viva's question. Again, you need to think about it. It involves optics. Why does the power of a corrective lens change if switching from spectacles to contact lenses? Again, this is something which we encounter in real life. If let's say you have a spectacle of -10 diopter, and if you want to wear a contact lens, you will not wear a contact lens of -10 diopter. For that matter, any other power that you may have, everybody, 6, 7, 8, if any of one of you, which a lot of you may have, everybody, you would have realized this, that when you go to buy a contact lens, the contact lens given to you is of a lesser power. Or if it is prescribed to you by an ophthalmologist for a lesser power, it is usually prescribed at around 9 diopter. Now the question is this: why does the power, the refractive power that you need, your eye does not change whether you're wearing a spectacle or contact lens, but why does the power change from spectacle to contact lens? Okay, so let us understand this. If you're asking me just why, I will simply write due to vertex distance. Now, what is the meaning of vertex distance? If this is my eye, this is where my spectacles are. Okay, this is my spectacle plane. But my contact lenses are here. Okay, am I making myself very clear? So this distance between the surface of the eye and the contact lens, this is called the vertex distance. We normally don't take it into account, everybody, but light rays are traveling through this area also. That means refraction is happening through this area, convergence or divergence, and that leads to change in the power. Okay, let me exemplate it for you. Okay, so let's say example number 1, there is a patient who's wearing +10 diopter specs. Now he wants a contact lens. What is the power which should be given to the patient? So first of all, everybody, let us use a simple formula, that power is equal to 1 divided by focal length. Power is equal to 1 divided by focal length, or I can say focal length, everybody, is equal to 1 divided by power, which in this case will be 1 by 10, which is equal to 0.1 meter. Okay, so we know that the focal length For specs of 10 diopter will be 0.1 meter, or I can say 10 centimeter. Till now we are clear? Now, everybody, let us calculate the secondary focal length. Secondary focal length means focal length for the contact lens. Now, we have seen that our focal length is 10 centimeter minus the vertex distance. Vertex distance is usually around 1.5 centimeter. So this is equal to 8.5 centimeter, or I can say 0.085 meters. So now what will be the power of contact lens, or I can say power at the eye, which is required, which will be equal to 1 by f. 1 divided by 0.085 meter, which if we'll calculate comes out to be around about this much. That means if I have to prescribe a contact lens which is at the ocular surface, then the power of that contact lens, if in plus, will increase. I hope we are pretty clear. Now let's take example 2. If I am wearing minus 10 diopter specs, I am taking 10 as the example because it is easier to calculate 10. Yes. So if I'm minus 10 diopter specs, everybody, what does my focal length become? My focal length of the specs becomes, which is equal to minus 10 centimeter. So my secondary focal length is equal to minus 11.5 centimeter, minus 10 minus 1.5, which is equal to minus 0.115 meters. So what will be the power of the contact lens or the power at the eye surface? It will be equal to 1 divided by minus 0.115, which will come out to be minus 8.70 diopters. Okay. So we see if we need to use a contact lens in a minus 10 specs, the contact lens comes out to be minus 8.7. Whereas if in plus 10, it comes out to be plus 11.76 due to the vertex distance. Yes or no? And that is why everybody, you see that some patients, to look at a near object, slide down their glasses. Look at your grandparents, look at your parents, everybody. They would be wearing a glass, but then they will slightly move it down the nose when they are reading a newspaper. Yes? Can you see this? Can you see this mentally? They have slid down the glasses on their nose. Why? Because when the glasses were near, the plus power, everybody, was less. And when glasses were slid down, the power became more. Yes or no? Minus 8.7 minus 10. I hope you understand my point here, everybody. Yes, I hope this is pretty clear to everybody. And that's all about the second question. Now we move on to the third question. What is Bell's phenomena? Okay, very good. What is Bell's phenomena? Demonstrate it, and what is the significance of it? Bell's phenomena, everybody, we have heard about this. Bell's phenomena. Bell's phenomena. This is core clinical question, which is a very simple demonstration in your postings, internships, and your third year postings, everybody. Anybody? Bell's phenomena. Okay. So let us see what is Bell's phenomena. Bell's phenomena is on attempting to close the eyes. On attempting to close the eyes move out and up. On attempting to close the eyes move out and up when examiner is keeping them open. Okay, let us see this, everybody. I am the examiner, I am the patient, let's say. I am keeping my eyes open. Okay, I have stretched the eyelids, I am keeping them open. Now everybody look at my eyes. When I try to close them, see my cornea, everybody. Can you see where my cornea is going? Everybody, I am trying to close, but the examiner through my fingers is opening. You will be able to see my eyes are going out and up. Okay, everybody. Okay, everybody, this is how I demonstrate Bell's phenomena to you. Very simple. Okay. Bell's phenomena is considered to be good if up and out less than one third cornea is visible. It is poor if up and out but greater than 1 by 2 cornea is visible. It is called reverse Bell's phenomena if the eyeballs go up and in. It is called inverse Bell's phenomena if the eyeballs go down and in. Okay. What is the significance? The significance is in ptosis surgery. Ptosis surgery done only if Bell's phenomena present. If Bell's phenomena is absent, that means after ptosis surgery, there will be some kind of exposure keratopathy that the eyes will not be able to, or the eyelids will not be able to close. So in cases of Bell's phenomena reverse, inverse or negative, we do not do ptosis surgery. Okay, everybody? Done? Okay. See in this patient, just like you saw in me, examiner is pulling them open, the patient is trying to close the eyes, the eyeballs are moving up and out, up and out. I hope all of us can see this. Up and out, there should be no confusion. Up and out, up and out. Okay, everybody? Okay, done? All right. Let's move on to the next question. Think hard but simple. Again, a patient presents with left head tilt. Okay. See, understand it as a clinical case. Viva question. The patient is standing in front of you, let's say. You've been asked this question. Okay, Viva question. Patient presents with left head tilt. He has right hypertropia. Right eye is hypertropic, which worsens on dextroversion and right sided head tilt. What is the diagnosis? Very difficult question. This question even is asked as an MCQ, has been asked as an MCQ. 99% students don't understand this, but this is a Viva question. You can count it on your fingers and do it. Okay, let us see how. The patient has right hypertropia. If the patient has right hypertropia, then I can say 4 muscles can be causing right hypertropia. Let me write the muscles first. Right superior rectus, right inferior oblique, right inferior rectus, right superior oblique. However, written them. Right eye, elevation with abduction. Right eye, depression with abduction. The clinical actions, I hope you remember. I hope you understand. That is how I've written these 4 muscles based on the clinical actions. Similarly, I will write on the left side. If you don't remember this, please brush up your squint lecture, everybody. Okay, we are discussing more than the facts which you already know, clinical vignettes. Okay, now for right hypertropia to occur, either the right depressors are paralyzed. Yes or no? If the right depressors are paralyzed, right inferior rectus or right superior oblique. If depressors are paralyzed, elevators will overact. Okay. Or as in cases of all paralytic squints, the other eye contralateral synergist yoke muscles, they may be paralyzed. Yes. So the other eye elevators are paralyzed. If the other eye elevators are paralyzed, the right eye elevators will also overact. Am I making myself very clear? Same eye depressors, same eye antagonists, opposite eye agonists or synergists. Am I clear till now? Yes? Okay. Now, secondly, which worsens on dextroversion? Dextroversion means looking towards the right side. Okay. So when I look towards the right side, right eye performs what, everybody? Abduction. Left eye performs what, everybody? Adduction. So these 2 muscles can be paralyzed, or these 2 muscles can be paralyzed. Are we clear till now? Yes? Yes? And the last thing which is written is, and they become worse on right head tilt. Right head tilt. Let's tilt the head towards the right side. What will occur, everybody? Can you see the head tilted towards the right side? Okay. So I have these 3 lines. Now I need to see which muscle is intersected by all these three lines. I will see there is only one muscle which is intersected by all these three lines, left inferior oblique. And that means it is a case of left inferior oblique palsy. Am I making myself very clear? So you just need to be able to draw these three lines and you are done with it. I hope I'm making myself very clear. Are we clear about this, everybody? Are we clear about this, everybody? Yes, sir. Done. So the answer is left inferior oblique. Just to make it clearer to you, I will present another case. I'll just write it. A patient presents with right hypertropia, which becomes worse on left gaze and right head tilt. Let's see how the answer changes. I will again write all the four muscles. Right superior rectus. You should do it with me. You should stop me from doing it. Okay. So first of all, I see again right hypertropia. When I see right hypertropia, I know right depressors or left elevators may be paralyzed. Worse on left gaze. Left gaze. When I look towards the left side, the right eye will adduct, the left eye will abduct. And on right head tilt. Right head tilt. Right head tilt. Right head tilt. What does the answer become now? Right superior oblique palsy. Okay. Right superior oblique palsy. I hope you know this. Yes or no? Primary hypertropia in right eye, then worse on opposite gaze, better on opposite tilt. Okay, worse on opposite gaze. On left gaze it is worse, and on right head tilt it is worse. So it will be better on which tilt? Left head tilt. I hope we are pretty clear about this. We understand this. Yes, this is a Viva question. You just need to be able to draw these three lines, and you're done with all these questions, which are basically Park's three-step test question, or I can call them Bielchowski's head tilt. A lot of students keep asking me questions on this simple clinical concept, simple Viva question for me. I hope we are ready. If you can solve this, you are a gold medal contendant. If you can solve this, that means you know the basics of your squint. You know the muscles, you know their actions, you know the squints, you know all the things, everybody. Yes, done? Okay. Let us move on to the next question. Question number 5. Parents of a 5-month-old baby, okay, complaint of, what do they complain of, everybody? Watering from both eyes in the child since birth. Okay. What is your diagnosis? Watering from eyes since birth simply means one thing: congenital nasolacrimal duct blockage. Yes or no? Yes. Due to non-canalization of the nasolacrimal duct, most commonly the non-canalization occurs at the level of the valve of Hassner. Yes, we know this. Demonstrate management of the same. So they are asking you to demonstrate the management of the same. So what is the management, first of all? The management is what, everybody? Management of congenital nasolacrimal blockage. Yes, it is lacrimal sac massage. More than 90% of the cases will get resolved from this. Yes, but lacrimal sac massage can only be done till 1 year of age. If by 1 year of age this does not resolve, if the parents are too reluctant, too busy to be able to do lacrimal sac massage, then you will need to do probing. Yes or no? Otherwise, basically this question is asking you to demonstrate the management of lacrimal sac. So how will you say? First of all, you are telling the examiner, I am the student, I'm telling you, you are my examiner. Okay, so wash your fingers thoroughly. Then with either your little finger or your thumb, when the child is breastfeeding, the position has to be breastfeeding like this, one eye, breastfeeding like this, other eye. Okay, slowly press the medial canthus, where you will feel a bone, where you will feel a small elevation. Press it, gently bring your down hand. Press it, gently bring your hand down along the nose. Press it, gently bring your hand down along the nose. That is how you do lacrimal sac massage. I hope it is pretty clear. Viva question, you can demonstrate it in 1 second. Just remember to say wash your hands. That is an important key, everybody. It's not that the mother was making food and now she's coming and doing it. Okay, it will cause infections, conjunctivitis in the newborn's eye. Okay, right. Next question, please. A patient has severe dry eye, okay, but with no discernible cause. There is severe dry eye, but you have tried to check for all the possible causes that can cause dry eye. The patient is not using lots of computer vision syndrome can cause it. There is no blepharitis. There is no Steven Johnson syndrome. There is no meibomian gland disease. All of those you have ruled out, the common causes of dry eye. What can you ask regarding systemic history? So all the common causes you have ruled out. You have thoroughly checked up the patient, but the patient is not resolving. You cannot find the cause. So in such cases, we ask about gastric bypass procedures. In such cases, we ask about gastric bypass procedures. Why do we ask about gastric bypass procedures? Gastric bypass procedures lead to vitamin A deficiency, and vitamin A deficiency is a known cause of causing what, everybody? Xerophthalmia. Yes, xerophthalmia leads first of all to dry, lusterless eyes, which can then lead to conjunctival xerosis and then corneal xerosis and all the things that you know about vitamin A deficiency. Am I making myself very clear? So this is something which a lot of time in practice we miss. We think it is just a dry eye, let us just treat it by lubricants. We increase the lubricants, we give anti-inflammatories, we do this, that. But we should be aware of all the systemic history of the patient also. Again, to become a good clinician, it is important to know everything about your patient first. History taking is paramount. That is why history taking is taught to you first and not patient examination. So always focus on your history taking. It can tell you tons about a patient which you would otherwise have missed. Okay, don't become biased when looking at a patient. Obviously it happens with experience, you are able to judge things, but you become biased. Oh, dry eye, okay, let's just write lubricants, let the patient go. But that is not the correct way to do it. Okay, now, so first of all, to yes, this is a fact that after vitrectomy, 2 years after vitrectomy, 50% patients need cataract surgery. After just 2 years, 50% of the patients who have vitrectomized eyes will need cataract surgery. But why is that so? Please understand, my lens is avascular. Yes, all the metabolism is anaerobic. My vitreous is also avascular. Okay, so the partial pressure of oxygen is very less in lens. Lens receives its oxygen from diffusion. Yes, vitreous acts as a barrier. Can I say that? Vitreous acts as a barrier to diffusion of oxygen into the lens from retina. I hope when I write these lines, it is more than sufficient to understand. So as soon as vitreous is removed, everybody, this barrier is removed. As soon as this barrier is removed, the partial pressure of oxygen in lens will increase. So when the partial pressure of oxygen in lens increase, it leads to oxidative stress. And due to this oxidative stress, we see that 50% of the patients develop cataract and even need cataract surgery within 2 years after vitrectomy. So vitreous is also important to keep my lens normal. Every structure has some importance. Yes or no, everybody? Yes. So these are some of your Viva questions, everybody, which we have done. Some important questions which otherwise we don't ask ourselves, which we don't answer, but they are relevant clinical questions which you should ask yourself. There are many more like this. This is just a snapshot, just a view into the clinical world, to open your brains, to attune yourself to using the facts that you know into reasons. So there are 3 ways of studying. You ask yourself what. Okay, what everybody asks, what is fact. But when you start asking why and when you start asking how, then that means you have studied well enough the what. Once you know the what, then you focus on the why and the how. Then you try to broaden your horizons. And to ask the why and the how, it is important to study for 5.5 years and not for the last year in internship. I know a lot of us have not, but it's all right. That's not the end of our journey. Post graduation will start. Yes, then you can start asking how and why. But that is imperative to have a clinical bend of mind. Clinical, that is the word we are looking at, right? Now, let us move on to the third segment of our clinical vignette video, in which I'll be discussing questions of slightly different kind, which are expected, which may come. I don't know. I don't set the paper. I am not, in the committee which sets the paper. But this is something which we can expect moving forward. So now the third section we are starting, which are theme-based questions, everybody. Yes, this is something which can be asked to you in the future. The only difference is that the multiple choice questions that we've usually have till now, we are used to doing, have 4 options. But these questions have multiple options. You will see 10 options in each question or 11 options somewhere also. Okay. Now, so the first theme is fundus dystrophies. So you will see all the options are fundus dystrophies, Oguchi disease, Stargardt disease, Leber's congenital amaurosis, and such. Okay. Now, vitamin A, chromatopsia, you can see all the options here. I will read the scenarios to you. I've just made 3 scenarios on the same options. There can be multiple also. Okay. Now, first question, everybody. A 16-year-old male, 16-year, presents with poor central vision. Fundus examination reveals white flecks, okay, fleck-shaped deposits on fluorescein angiography, FFA. Fluorescence from choroidal circulation is not seen. Okay. Don't look at the options. See, that's what I want to do. 4 options you can rule out, but out of 10, 11 options, it is very difficult to rule out. So that is how they are different from. Yes. So you have to focus on what is given in the information actually. So you can't do them as MCQs. You have to actually think them as cases and then just try to verify your thinking from the options, whether that option is even given or not. Okay. So what do I note in this question, everybody? First of all, I see that the patient is a juvenile. 16 years of age. Yes. Then the patient has loss of central vision. Okay. Central loss of vision. Central vision comes from macula. We are talking about dystrophies. So that means it is more likely to be a macular dystrophy. So what is the most common macular dystrophy occurs in juvenile? Think about it. Think about it. Most common hereditary juvenile macular dystrophy is Stargardt disease. Okay. So from this, I know it may be Stargardt disease. Then in Stargardt disease, fleck-shaped deposits are seen. Yes. In Stargardt disease on FFA, we see something called as a dark choroid sign or a silent choroid sign. Yes. Yes. So fluorescein angiography shows that choroidal circulation is not seen. So there is no background fluorescence, everybody. Yes. That makes it very simply for me Stargardt's disease. Okay. So that's how you solve clinical questions. Now, let's move on to the second case. A 25-year-old man, okay, has poor vision at night, nyctalopia. The ERG shows normal. ERG has normal. The fundus in both eyes shows color changes during dark adaptation. All right. So this we are talking about now a case of nyctalopia. When we are talking about nyctalopia, the first thing that comes into my mind is retinitis pigmentosa. Yes, but retinitis pigmentosa we know has negative ERG or not abnormal ERG. Sorry, not negative ERG, abnormal ERG. It will die down. Yes or no? That's the investigation of choice. But here the ERG is normal. Now, ERG normal, EOG investigation of choice. Do I know something? ERG normal, EOG investigation of choice. I think I've read this. I've read this in a disease called as Best's macular dystrophy. So can Best dystrophy be the answer? Can it? No, because it is macular. Macular will lead to loss of day vision. Day vision is known as hemaralopia, loss of day vision, not nyctalopia. So that cannot be the answer. Okay. So now I focus on this line. The fundus in both eyes shows color changes during dark adaptation. The fundus has a golden sheen in illumination, and this golden sheen slowly disappears in dark. I've read this somewhere. I've read this as a fancy name, Mizuo Nakamura phenomena. Yes. So that means nyctalopia, Mizuo Nakamura phenomena. My diagnosis becomes option A, that is Oguchi disease. Okay, everybody, Oguchi's disease, Mizuo Nakamura phenomena. So the only confounding factor in this question was 25-year-old man. Oguchi disease usually occurs in infants. The presentation is a 25-year, that's all. Yes, the patient did not present to you. He has had nyctalopia, but he has not presented to you. So that was the confounding factor. But based on the other factors, I think the answer was pretty clear to us. Okay, now, third question. A 2-year-old boy, everybody, a 2-year-old boy has poor vision since the age of 5 months. So this is now different from second question. In second question, only the age of presentation was given, not the age of onset. Had it been given 25-year-old man has poor vision since past 3 months, then it would have been difficult to diagnose Oguchi's disease. Yes, but because no onset was given in number 2 question, so that way you are free to answer Oguchi disease. So third question, 2-year-old since the age of 5 months has absent ERG, okay, and poor pupillary reaction to light. Okay, he has tendency to rub his eyes with his fingers. So everybody, this is a simple classic case which presents with 3 things, and those 3 things are absent ERG, normal pupillary reaction, and rubbing. This is a case of Leber's congenital amaurosis. This is another important cause of loss of vision in the infancy, everybody. Age onset at 5 months of age. Leber's congenital amaurosis. If you've never heard of this, just remember this as it is. Vitamin A deficiency, you already know, will lead to xerophthalmia. Achromatopsia, you know, color blindness, which can be rod monochromatism or cone monochromatism. Gyrate atrophy is of the choroid, you know. DIDMOAD, diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. These are linked with everybody. There is a condition DIDMOAD, Jair Bear Wolfram. Yes, so these are Wolfram hereditary optic neuropathy. I hope you remember this, DIDMOAD. Then retinopathy of prematurity, you know, Hermann-Podolak and Shinya-Higashi syndrome. All these things you know through your retina. All right. Now, let us move on to the second such question, thematic question. The second thematic question now everybody is on neuromuscular disorders. Okay. Now, the lead given to us is match the clinical scenarios with the best possible diagnosis. Okay. We have to diagnose. Number 1. A 50-year-old man has polydipsia and polyuria. As soon as I hear polydipsia and polyuria, the first diagnosis that comes into my mind wired is DM, diabetes mellitus. Yes, actually clinically we don't see so much, but this patient is complaining polydipsia and polyuria. Okay, develops sudden onset vertical diplopia. Okay, sudden onset. Examination reveals a right hypotropia and the pupil are normal. All right. So basically the question is right hypotropia. Right hypotropia. Are they asking us which muscle? But for which muscle, if we go back to our Viva question that we have done just a little while back, everybody, the sufficient information is not there. Head tilt and worse gaze. So they are not asking us that. Okay. Okay. So that means they're asking us something else. Right hypotropia. Right hypotropia means what? Let us see. Right eye hypotropia means that right eye is not able to elevate. Can I say this? Right eye is not able to elevate. And due to this, the patient has diplopia. Okay. But the pupil are normal. This is what is given to us. Pupil are normal. And I know it is the case of diabetes mellitus. Now, if the right eye is not able to elevate, that means superior rectus and inferior oblique are paralyzed. Both these muscles are supplied by third cranial nerve. Third cranial nerve can be affected in diabetes mellitus, yes, but diabetes mellitus is an ischemic cause. Ischemic cause, as we had seen a little while back in a case on diplopia and ptosis, are pupillary sparing because they affect only the central nerve fibers. Pupillary fibers are peripheral. Yes? Am I getting near to you? So it is a third cranial nerve palsy which is pupillary sparing, which is due to diabetes. All the facts match each other. So that means my answer is option G, everybody. Okay? Hypotropia. Now the answer could have been option A, oculomotor nerve palsy due to aneurysm of the posterior communicating artery. But in this case, the pupil would have been abnormal. There would have been mydriasis in that, as we have already seen, everybody. Yes, I hope we are pretty clear about this. There is no confusion in this. Pupil is normal, so Horner syndrome cannot be the answer. Yes or no? Myasthenia gravis cannot be the answer because there is no fatigue. Blepharospasm is absolutely different thing. Superior oblique palsy would have presented with hypertropia. Just some of the lesions that I'm making you go through. Okay, done. Now, let us move on to question number 2, everybody. A 30-year-old woman develops binocular double vision. Okay, diplopia case again. Examination reveals limited adduction in both eyes. Both eyes limited adduction. Adduction is a function of medial rectus. Bilateral medial rectus palsy. Let's read. And fine nystagmus on abduction in either eye. So when either eye is abducting, then it is showing nystagmus. Pupil examination reveals a right-sided afferent pathway defect. Okay. What is the diagnosis? Okay. It is slightly difficult to understand. I don't know. Let me try to see if it is difficult to understand, everybody. Let me try to see. We are saying that when any of the eye is adducting, this is my right eye, this is my left eye. So let's say I'm looking towards the left side. My left eye is abducting, but my right eye is not adducting. No adduction. Yes or no? Adduction will occur only on the opposite gaze. When I'm looking towards the right side, my right eye is able to abduct, but my left eye is not able to adduct. Okay. And we know that during abduction, so left eye during abduction is showing nystagmoid movements, and this is also showing nystagmoid movements. Okay, what can I think of? What can I think of? I can think of something, yes. So I see abduction present, adduction absent. That means medial rectus is the only muscle which is not functioning. Right eye medial rectus is not functioning. Right eye MLF lesion. Similarly, left eye is not functioning. Left eye MLF lesion. That means both MLF are lesion. That means it is bilateral internuclear ophthalmoplegia. Bilateral internuclear ophthalmoplegia. Am I correct here, everybody? Yes or no? Nystagmoid movements is giving us both eye adduction. So usually we are used to hearing single eye questions. This is a bilateral question. It is a bilateral internuclear ophthalmoplegia. Let us search for the option quickly. Internuclear ophthalmoplegia is not given in the options. What is the answer? And what does right eye afferent pathway defect have to do with it? Let's think more, guys. Let's think more. Internuclear ophthalmoplegia. What is the most common cause? Multiple sclerosis. Yes, guys, multiple sclerosis. Now, what are the ocular manifestations of multiple sclerosis? Can be remembered through the mnemonic INO. INO. Okay, everybody. What is INO? N for nystagmus. I for internuclear ophthalmoplegia. O for optic neuritis. Am I clear? Why is it a beautiful mnemonic? INO, internuclear ophthalmoplegia. So internuclear ophthalmoplegia, INO itself becomes the mnemonic. N for nystagmus, O for optic neuritis. Optic neuritis leads to what, everybody? Optic neuritis leads to RAPD. Am I making myself very clear here? So multiple sclerosis is the case which is presenting with optic neuritis in the right eye and bilateral internuclear ophthalmoplegia. Am I making myself very clear? Yes or no, everybody? Yes. So I know these questions become more difficult. That's why I have given it to you. You can't see the options first. You have to be good at your clinics. You have to be good in your thought process, in the what, the how, and the why. And then only you will be able to solve these questions. Ruling out does not work here, everybody. Yes? Done? Now, let us move on to the last thematic based question that I will be presenting in this series of clinical ophthalmology video, everybody. Optical coherence tomography, straight image based lead questions, match the OCT picture given with the most likely diagnosis. When I see the first image, what do I see? I see a lot of cysts form. As soon as I see a lot of cysts form, I know it has to be a case of cystoid macular edema. No history given, nothing given. Answer is option A, macular edema. Okay. When I see second image, then I see there is elevation of the retina. Now I know that elevation of the retina occurs in retinal detachment. It occurs in CSR. CSR is central serous retinopathy. So can these be the answers? Let us search the options. Central serous retinopathy is there, retinal detachment is there, both are there. But now both are there, what is the answer? Both of them are wrong answers. Why are they the wrong answers, everybody? Because as I've already said, we need to see the red line, everybody. See this red line. See this red line, everybody. What is this red line? The red line denotes pigment epithelium. The red line denotes retinal pigment epithelium. The retinal pigment epithelium has also detached. In CSR and RD, what would have occurred, everybody? The red line would have been here. Yes. So then we would have said, this is the retinal pigment epithelium. This is the neurosensory retina. This is the subretinal space. And then the answers could have been RD or CSR. But here the answers can neither be RD nor CSR. Can you understand this? Everybody for me, yes. This is pigment epithelial detachment. Can we find? Yes, we can find pigment epithelial detachment, which is seen in cases of wet ARMD. Wet ARMD has two signs: pigment epithelial detachment, number one, and number two, choroidal neovascularization. Yes or no, everybody? Yes. So none of this is the answer, neither this nor this. Okay. Now let's move on. The last image on OCT, everybody. Last image. What do we see? We have not seen this image before. Okay, this is the retina. In the retina, there is a hole. This much we can see. Macular edema has already been done. Pigment epithelium has already been done. Choroidal neovascularization will not look like this. It will have to do something with choroid. Retinal detachment, CSR look different, we know. So now it can either be macular pseudohole, stage 3 macular hole, or stage 4 macular hole. All the three options have hole in it. Now we need to know a little bit about the GAS classification, GASS, GAS classification of macular hole. If you don't know this, I'll just quickly tell it to you. Through photographs, this is the GAS classification. Stage 1 is impending macular hole, or what we call as a pseudo hole. Here there is only loss of foveal depression. As you will be able to see in the photograph, fovea, instead of getting depressed, is slightly elevated. Yes or no? That is called impending macular hole or pseudo hole. Okay. Now, stage 2. You will see both these photographs of stage 2. In stage 2, you see that there is a full thickness retinal defect. Full thickness, everybody. Yes, but it is less than 400 micrometers in size. And this is called an operculum, pseudo operculum. It is attached. And if you focus faintly on this line, everybody, and on this line, everybody, this is our vitreous, the posterior face of vitreous. This is still attached. Okay. Similarly, in stage 3, we say full thickness neurosensory retinal defect, but it is greater than 400 micrometers in size. In stage 4, everybody, what occurs? Complete PVD. That now the vitreous is no more attached to the retina at any point, like in stage 2 or even slightly in stage 3, everybody. Making myself very clear? Now, if I show you the photograph again, you see the vitreous is still attached. Yes or no? The vitreous is still attached. Full thickness more than 400 micrometers it must be. Sir, how do we measure more than 400 or less than 400? Okay, but the examiners are smart. They know you can't measure more than or less than. So they have not given you stage 2, stage 3. They have even instead given you options stage 3, stage 4. They want to know whether you know that stage 4 presents with PVD. Here vitreous is attached. You can see that means the answer is stage 3 macular hole. So the examiners are going to give you difficult questions, but not impossible questions. You have to believe in the examiner. Don't think, kya de diya. Don't think that. Okay, everybody? And that's all about the clinical vignettes from my side here, everybody. I hope you have been able to learn something. You have been able to understand something. But before we go, one more. Why not? Let us just see quickly one more, everybody. A very simple clinical vignette, which is encompassing both ophthalmology and pharmacology. Consider it your bonus clinical vignette. Yes, we encounter this every day, and that is what is important here. Yes. Now, for the clinical scenarios given, match the anti-glaucoma drugs. Get ready. You can solve this. Yes. Okay. A 78-year-old woman, okay, age is irrelevant, I think, has been taking anti-glaucoma eye drop for past 20 years. The pressure in both eye, this. Examination reveals the presence of black deposits in the lower tarsal conjunctiva of both eyes. Black deposits in the lower tarsal conjunctiva. Can you see, everybody? Black deposits. Okay. Adrenochrome deposits. Adrenochrome. They are called adrenochrome black deposits because they have something to do with adrenaline. Yes or no? Adrenochrome. So we know it is a side effect of alpha agonist dipwefrin. So let us find dipwefrin. Yes, it is there. So the answer is dipwefrin. Now, let us move on to question number 2. A 54-year-old woman with a past history of ophthalmic shingles, everybody, herpes zoster, develops right anterior uveitis. Okay. Raised intraocular pressure, obviously, and mild corneal edema. She is on tricyclic antidepressants. So I can say this is basically a case of uveitis plus raised IOP, inflammatory glaucoma, uveitic glaucoma. Okay. She is on tricyclic antidepressant, TCAs, for post-herpetic neuralgia. Which anti-glaucoma medication is preferable? Okay. So we need to reduce the IOP, but we have to keep in mind all the other factors. So first of all, can latanoprost be given? The answer is no. Why latanoprost cannot be given? Because latanoprost causes uveitis and it causes reactivation of herpetic keratitis. Pilocarpine also causes inflammation. It also increases the uveitis. Both these drugs cannot be given. Okay. I'm not ruling out. I'm just thinking and then just cutting the options here. Okay. Then she's on tricyclic antidepressants. CNS suppressants. Brimonidine can be given? No. Brimonidine passes the blood-brain barrier. I cannot give brimonidine also. If I cannot give brimonidine, I'm not going to give apraclonidine also. So can I give oral acetazolamide? Acetazolamide? No, I don't think. Why I don't give acetazolamide? Acetazolamide can increase what, everybody? Can increase the corneal decompensation. Okay, my cornea is already edematous. So that means oral acetazolamide and dorzolamide are also ruled out. I have 4 or 5 groups. One are prostaglandin analogs. Can't be used. Alpha agonists. Can't be used. Carbonic anhydrase inhibitors. Can't be used. Pilocarpine can't be used. What is left? Only beta blockers. That means the answer to this question will be timolol. This is what a nicely constructed clinical case is like. You have to be aware of everything before you are starting an anti-glaucoma medication, guys. Yes, none of the drugs could be used except timolol in such a case. You have to be aware of everything. Prostaglandin will increase the inflammation. Pilocarpine will increase the inflammation. Alpha agonist, blood-brain barrier, carbonic anhydrase inhibitors, corneal decompensation. Yes, all the groups are gone. Okay. Now, third, a 78-year-old asthmatic, asthma, oh, you understand, has bilateral mild ptosis and early glaucoma with raised IOP. He was given an anti-glaucoma treatment. On review 4 weeks later, the pressure and ptosis improves. So basically the question is ptosis has improved. Which anti-glaucoma medication might have been given? Very simply the answer is apraclonidine, because apraclonidine causes eyelid retraction. We know this as a side effect. Simple question, nothing doing here. Okay, clinical scenarios which you need to know to be able to answer such questions. The only understanding that I'm trying to give you here is don't believe in rule out here. These questions will be much more difficult than your normal MCQs. Understand, read the question, think about all the clinical information which is given to you in each case, and then only proceed to solve the questions. This is just a sneak peek into how your life will be once you're a postgraduate, once you're a practicing doctor. And that is what you should understand. You are going to become clinicians, everybody. Think like clinicians. Ask each other these questions. Go to your postings. Learn to love medicine. Yes, MBBS you fall in love with. Once you fall in love with it, you enjoy it. It is infectious. Not an infectious disease, but it is infectious. The more you know, the more you want to know. The more you know the what, the more you know to know the how and why. And your satiety keeps on going up. Your hunger does not get satisfied, everybody. Satiety level keeps on increasing. You need more information every day, every hour to be able to satisfy yourself. And once you are able to satisfy, that is a feeling which all of us want. Thank you guys for having this session, attending this session. If you have any queries, please feel free to get back to me on either of the social platforms that you're aware of, or please comment down below on what else you would like, and we will make sure that we are able to meet your expectations. Thank you guys.